Welcome everyone. My name is Emese, Kasznár, and in the next few minutes I would like to present you my progress in the past 6 months. My project is physical activity in inflammatory bowel disease. I work at Translational Pediatric Institute and I'm a medical doctor. I would like to improve the management and quality of life of IBD patients, and for this I would like to encourage them to exercise to reduce their disease burden. I have 3 ongoing projects right now. The first 2 will be systematic review and meta-analysis, and the third one will be a protocol for international randomized clinical trial. So let's jump to the first one. It will investigate the effect of structured physical exercise in inflammatory bowel disease. We know that inflammatory bowel disease affects the gastrointestinal tract, but not just that. Patients tend to have decreased physical activity, decreased bone mineral density, and muscle mass. They can also suffer from anxiety and depression. In 2022, there was a meta-analysis in adult IBD population, and it showed that physical activity can have a beneficial effect on all these outcomes. But we know that 25% of the population are diagnosed in childhood. So we would like to include them in our analysis. Our aim is to analyze the effect of structured physical exercise on disease activity and quality of life. For this, we will use the PICO framework. The population will be the IBD patients. The intervention can be any structured physical exercise, and we will compare the outcomes to the baseline measurement. The primary outcomes will be the disease activity and the quality of life. Our hypothesis is that physical activity beneficially influences these outcomes, and the clinical implication is to encourage IBD patients to exercise more. On November 16th, we did our search with the following search key, and we had more than 13,000 hits. After the selection process, we found 37 eligible articles. We're done with the risk of bias analysis, and I have some preliminary results I can show you. The first one is inflammatory bowel disease questionnaire, which is a disease-specific health-related quality of life questionnaire. It ranges between 32 and 224. The higher score means better quality of life. Patients in remission usually have around 170 points. As you can see, we included 7 studies, overall 141 patients. The heterogeneity was high. The reason for this is probably that they have different exercise interventions for different period of time. The change was 15.48, which means that after the intervention, their quality of life improved by more than 15 points. This is clinically relevant and statistically significant. The first 2 studies, you can see that the change was not as big as in the other studies. The reason for this is that they already started from a higher score. We checked these 2 studies and we did not find any reason for this. The second outcome is a disease activity score for children with ulcerative colitis. The range of this score is between 0 to 85. Under 10, they are in remission, and above 65, they are in severe disease activity. We could include 3 studies, overall 23 patients. The heterogeneity was moderate, and the change was minus 4.1, which means that after the intervention, their disease activity decreased by 4.1 points. This is clinically relevant, although statistically not significant, because of the small number of patients. As you can see, in the second 2 studies, the change was not as big, and the reason for this I can show you on a diagram. As you can see, in the first study, there was more patients in mild disease activity. That means they had a score above 10. And in the second 2 studies, there were more patients in remission. That means they could have a point of 0, which did not allow the change to the mean to change as much. But if you check the after disease activity, you can see that in every study, more patients got into remission. The third outcome is Harvey-Bradshaw index. This is a disease activity index for adults with Crohn's disease. As you can see, it goes the same. So under 5, they are in remission, and the higher score means more severe disease activity. We could include 3 studies with over 59 patients. The heterogeneity was high here as well, for the reasons I mentioned before. The change was minus 2.06, which means that after the intervention, these patients' disease activity decreased by more than 2 points. This was clinically relevant and statistically significant. As you can see in the first two studies, the patient's disease activity was in the mild stage, and after the intervention, they got into remission. So my second study is comparing the physical activity between healthy population and IBD patients. IBD prevalence in 2019 was 4.9 million worldwide. This is a relapsing-remitting disease, and some data suggest that even in remission, patients tend to have reduced physical activity. We know that reduced physical activity can lead to metabolic syndrome, sarcopenia, decreased bone mineral density. So our aim is to investigate the physical activity of healthy population and IBD patients. For this, we will use the PECO framework. The population will be the population, the exposure will be inflammatory bowel disease, the comparator will be healthy control, and we will have 4 primary outcomes: metabolic equivalent of task minutes, time spent in moderate to vigorous physical activity, functional capacity, and fitness. We will have 5 more secondary outcomes, and our hypothesis is that healthy people are physically more active than IBD patients. So our clinical implication is to encourage physical activity in this population to reduce the risk of osteoporosis, sarcopenia, and metabolic syndrome. We used the same search key as I showed you before, so we had the same hit, more than 13,000 articles, and after the selection process, we had 80 eligible articles. We are done with the risk of bias analysis, and now we are waiting for some results. As you can see, in the aerobic fitness, we cannot do an analysis because only one study mentioned this parameter. My third study is investigating the effect of structured physical exercise in children with Crohn's disease. 1/3 of adult IBD patients have sarcopenia, which means they have decreased muscle mass and function. We know that sarcopenia can lead to decreased therapeutic response, it can lengthen the postoperative stay, and can lead to decreased bone mineral density. In pediatric Crohn's disease, the first-line therapy is exclusive enteral nutrition. This is a specialized liquid formula which they take for 6 to 8 weeks. We do not know the effect of exclusive enteral nutrition on muscles, and also we do not know the effect of structured physical exercise on the prevention and treatment of sarcopenia. So our aim is to investigate the effects of structured physical exercise on sarcopenia in pediatric Crohn's disease. For this, we will use the PICOT framework. The population will be children with Crohn's disease. The intervention will be exclusive enteral nutrition plus structured physical exercise. The comparator will be only those with exclusive enteral nutrition. The outcome will be sarcopenia, which we will measure at baseline and 8 weeks later. Our hypothesis that physical exercise mitigate or prevent sarcopenia in Crohn's disease patients, so we would like it to be incorporated into the therapeutic guidelines. So in overall, I have 3 ongoing projects right now. The first 2 I hopefully finish this year, and the third one next year. Thank you for your attention. Somewhere something incredible is waiting to be known.
I would like to ask that which kind of exercise can these patients do? Because most of them have, for example, stomach bag. How does it affect their ability to exercise?
Thank you for your question. In the study which we could analyze, they reported if patients or they excluded those patients who could not do physical exercises or structured physical exercises. And they had we had many types of exercises: yoga, exergames, aerobic, resistance training exercises. So we included all those. And for now, we do not know which one is the best for these patients. And sadly, those with the stomas, there are no available data for them. Thank you.
Further questions?
Thank you for your presentation. It was excellent. My question is related to your first project. I'm just curious about whether you have information on their diet, because diet can also influence the quality of life. Were there dietary intervention as well, or just physical intervention?
Thank you for your question. In one study, they reported a lifestyle intervention which included dietary advice and physical exercise intervention, but it was only an advice, so not a strict diet. Thank you.
Thank you for your presentation. You mentioned the prevalence of anxiety and depression in your slides. How could you translate your results in respect to that? What would you say the connection between physical activity and these psychological alterations?
Thank you for your question. So we would like to measure it with the health-related quality of life, because this IBDQ has 4 domains: the systematic, the emotional, and the bowel, and there's a functional domain for it. So the emotional domain contains for the anxiety part. And my theory is that, or some data suggest also that physical activity can induce the endorphins and the overall psychological part of the patient, so it can improve their overall well-being. Thank you.
Sorry, I have a question too. Thank you for the presentation. Regarding to your second topic, my question is that you have any data about the severity of the EBD as well in the population?
Thank you for your question. Yes, there are studies which reports patients that how many patients are in remission or in moderate and mild disease activity. Some has separate data, so we can do subgroup analysis, hopefully, in patients in remission or in mild or moderate disease activity as well. Thank you.
So congratulations, and I just want to ask 2 things. The first one is connected to the third project. So how would you define this structured physical activity? I cannot imagine myself what will be the definition. And for the first project, what was the reason for the high risk of bias in domain 8, for example, as you showed in the result? Thank you.
Thank you for your question. I will start with the second one. So we used the minor risk of bias tool, and in that the 8th domain is about the previous measurement of the patient number. So if they did any measurement, how many patients will be included in the study, and in most of the studies they did not do that, sadly, because they were not RCTs, and that's why they are not as high quality studies. And the other one is that the loss of patients over time was more than 5%. And for the first question, we will hopefully do an individualized structured physical exercise. We are planning, there's a guideline which is not a physical activity guideline, but more like a nutritional guideline. And it mentions that in sarcopenia, they advise resistance training, although they do not have any data to support this. So we are planning to do resistance training in this population and do it for 8 weeks, 3 times a week. We are not sure about that yet.